Uh, Good evening, Purvish sir. Yes, back to Pune, sir.
So nice to hear that. Yeah, excellent.
Thank you, sir. Thank you, sir.
Uh, Vivek, sir, we can start whenever you're ready, sir.
Yeah. A very good evening to all of you. I welcome you to the fourth series of Asian Cardio-Oncology Society conference. And it has been an exhilarating experience till now. We have got really good responses regarding this initiative. Straight away, will go ahead with our meeting, and I'll introduce our keynote speaker today, Dr. Arjun Ghosh. Dr. Arjun Ghosh is a cardiologist at Bart's Heart Center in London and at University College London Hospital. He is the first cardiologist in UK who is specialized in cardio-oncology. So today we would be listening from the pioneer himself. He established the first global cardio-oncology MDT at the Bart's Heart Center, and he runs the United Kingdom's only national cardio-oncology study till date, and organizes the only pan-European cardio-oncology symposium. So everyone, I welcome Dr. Arjun Ghosh. Over to you, sir.
Thank you very much, Vivek. I'll just see if I can share my screen. Can you see my slides?
Yes, sir, it's visible, sir.
Great. So thank you very much for that very kind introduction. And it's great to be part of this process of ACOS and what the society is trying to achieve. So let me start with the presentation on 5FU cardiotoxicity. So I have no disclosures. So I will give a brief, very brief background of cardio-oncology and what the setup is in the UK, and then just to set the scene and then go on to the rest of the talk. So in the UK, cardio-oncology has been around for around 10 years. And as mentioned, I'm the first person to be appointed specifically in it. And I'm very lucky because I work at Europe's largest cardiac center, which is Bart's Heart Center, and I work at Europe's largest cancer center, which is University College London. And I think that it's very important that if we want to establish cardio-oncology as a field, we need to have the collaboration and the communication between, big cardiology centers and big cancer centers. And as mentioned, I'm involved in a number of society roles, and our services are growing. Now, we see all number of patients, both hem-onc, solid-onc, late effects, and today's talk will be on 5FU cardiotoxicity, but I'll also be talking later in the series about CAR T-cell cardiotoxicity. So, I know that this audience is very much attuned to what cardio-oncology is, and we're all believers in the field, but as a general introduction for anyone new, cardiovascular disease is the leading cause of morbidity and mortality worldwide, as per the World Health Organization, 17 million deaths a year. Cancer is second on that list with 9 million deaths a year. Cancer, unfortunately, is likely to increase, and the number of cancer cases is predicted to rise significantly over the next 20 years. Currently, half the cancer people who are affected with cancer survive at 10 years. And the great news is that cancer treatments are becoming more and more effective, and people are living longer. However, that does mean that a lot of these people do have comorbidities, and cardiovascular disease is a big one for cancer patients. So briefly, what is cardio-oncology? Cardiac care of cancer patients. This can be at any time in their journey. This can be pre-treatment, and we'll come on to this with the 5FU cardiotoxicity. It can also be before cancer surgery, and the majority of treatment is, or the majority of where cardio-oncology comes to play is during cancer treatment, but of course there's also the role of late effects. So, cardiotoxic complications. We have the chemotherapy broadly and the radiotherapy, and today's talk on the 5FU will mainly be concentrating alongside the ischemia, arrhythmias, also fibrosis as well. So, cardiotoxicities of commonly used cancer drugs. As you can see from this slide, some of the commonly used cancer drugs have a number of different cardiotoxicities. And in today's talk, 5FU, we can see from this table itself that it can cause systolic dysfunction, angina, ACS, Takotsubo, and I'll come on to that in more detail now. So, coming on to the main bulk of the talk, use of fluoropyrimidines. So I don't need to explain this, of course, to the oncologists, but to some of the cardiologists, fluoropyrimidines like fluorouracil and capecitabine are a mainstay of chemotherapy regime for many malignancies, predominantly GI, but also head and neck and breast. It's the third commonest chemotherapeutic agent worldwide for solid malignancy treatment. It's frequently combined with radiotherapy due to the radiosensitizing properties. Now, what are the cardiotoxicities that we see with fluoropyrimidines? Now, fluoropyrimidine cardiotoxicity was first described many years ago, back, nearly 70 years ago in the 60s. And few clinical trials, unfortunately, have taken place where you've prospectively looked at 5FU or capecitabine cardiotoxicity. And as a result, in the studies which have taken place, a lot of these are retrospective, and the definitions of fluoropyrimidine cardiotoxicity have been inconsistent. We also know that there is a large spectrum of cardiotoxicity, and it's important to note that after anthracyclines, of the cytotoxic chemotherapies, 5FU is the second most cardiotoxic. In terms of the spectrum of cardiotoxicities, as I mentioned, there are a number of different potential cardiac side effects. You can get ischemia, chest pain, acute coronary syndrome, left ventricular systolic dysfunction. You can also get arrhythmias such as VT. In one series, the risk of death actually was 1 to 18%. Now, according to some studies, there is potentially an increased risk of cardiotoxicity if you have pre-existing heart disease or CKD, if there's been previous chest wall radiotherapy, and if there's concurrent cisplatin therapy. In this review by SAIF of 377 patients with 5FU cardiotoxicity, they looked at the cardiovascular risk factors for these patients, and they found that conventional risk factors like smoking, diabetes, high cholesterol, and a family history of heart disease was found in 37% of patients. What they also found was that smoking was the commonest risk factor in those who developed cardiotoxicity. Now, it's also important to note that the majority of patients actually developed cardiotoxicity without any pre-existing cardiac risk factors. So what are the cardiotoxicities with the fluoropyrimidines? Now, this is an interesting study by Upshaw and colleagues from America. They looked at a regional cancer network and the number of patients enrolled in studies there. They looked at 16 studies of patients who were enrolled with fluoropyrimidines, and what they found was that there were very commonly patients were excluded if they had pre-existing cardiovascular disease. And of those patients who were recruited, only 43% of those patients were actually asked or followed up specifically looking for cardiovascular complications. So in the majority, they didn't even look into the cardiac complications. So this is a table showing some of those studies. And I would just draw your attention to the column here on the right, where you can see that no cardiac side effects were even asked for, despite that being a common toxicity. So what is the pathophysiology of accelerated atherosclerosis and plaque rupture in cardio-oncology in general? Now, we know that a lot of cancer treatment, and this is not just 5-FU, but other cancer treatment can cause endothelial damage, vasospasm, platelet activation and aggregation, and this can sometimes attract cholesterol particles and cause plaque formation. Now, what this does is it can cause potentially unstable, lipid-rich coronary plaques, and of course, this can cause atherosclerosis, and it can cause stenosis and chest pain and so on. Angina symptoms can, of course, occur if the stenosis are hemodynamically significant. And we also know from general cardiology that if the plaques have a large content of lipid, these are often friable and more prone to rupture and then causing occlusion and an acute coronary event. So how does 5-FU and capecitabine, how do they cause coronary ischemia? Now, from various studies, we've seen that coronary vascular endothelial dysfunction can occur, leading to coronary spasm and thrombosis. Now, the problem is, as previously mentioned, the incidence range varies widely between studies, and mainly because a lot of these studies are retrospective and the definitions of maybe ACS angina vary between the studies. 5-FU is a radiosensitizer, and this is why it may enhance radiotherapy-induced thrombosis in certain patients who are receiving radiotherapy. And what we've also seen is that chest pain can be more common with continuous infusions compared to bolus infusions, and it's unclear if this is a dose-dependent phenomenon or not. So let's come on to what the clinical picture is, and I'll kind of focus on bolus infusions versus continuous infusions. Now, for the cardiologists amongst the audience, 5-FU can be administered IV as part of the FLOX regime, or it can be given as a continuous infusion as part of a FOLFOX regime. And of course, this can differ from country to country. And the bolus infusions in the UK are typically given over 2 to 15 minutes. And what we find is that chest pain often occurs during the push or immediately after the first cycle, up to around 12 hours after for the bolus infusions. And if the patient doesn't get the symptoms in cycle 1, it's unusual for the symptoms to occur afterwards. Here, the pain, the description of the chest pain is often typical for angina. So it does sound like a cardiac chest pain. And what we often see on the ECG, typical ischemic signs on the ECG. And this can mimic ST elevation infarction, it can mimic ST depression, so ongoing ischemia. Now, the picture is different when it comes to the continuous infusions. Here, the chest pain can occur with the first cycle, it can occur with the second cycle, and it typically occurs a day to 3 days after the infusion. And it's important to note also that the pain is not necessarily typical in nature. So the patient may not necessarily complain of exertional chest pain or tightness. They can describe it in a very atypical fashion. And the symptoms can recur cyclically during the infusion, and they can persist for hours to days after the infusion is completed. Due to this odd nature, atypical nature, patients may actually ignore the pain, or they may not feel that this is necessarily a cardiac chest pain, and they may not bring it to the attention of the physician. And what's often seen is that if the treatment is continued, symptoms typically occur earlier in the progressive cycles, and they can sometimes be more intense in nature and in duration. And this is just a table just illustrating the points I made in terms of the bolus infusion and the continuous infusion. So let's come on to how 5-FU might be causing cardiotoxicity. And I think I could skip the rest of this section of slides just with this first point, that the definitive mechanism is actually undefined, and there are a number of different postulated hypotheses, and I'll go through that. But I think in mechanism, when there are a number of distinct hypotheses, that just means that people still don't really know. As discussed, the dose and subsequent serum concentrations of 5-FU, they don't necessarily predict cardiotoxicity. There are a lot of different mechanisms that have been postulated: vascular endothelial damage, coronary artery spasm, direct myocardial toxicity, and also increased thrombogenicity. Now, the reason that vasospasm is often postulated as a cause is that when these patients go on to have coronary angiography, we often see that the coronary arteries are actually pristine and that there is no stenosis. This is why it's felt that maybe it's spasm at the time. Some studies have also shown that when 5-FU is infused, you can get brachial artery vasoconstriction immediately after the injection. However, we also know that symptoms of 5-FU cardiotoxicity can occur hours or even days after the infusion. So this may rule out spasm in this context. What we've seen in some in vitro models is concentration-dependent vasoconstriction on vascular smooth muscle cells. But again, this is different to other studies where there is no dose-dependent effect. Interestingly, as I previously mentioned, left ventricular systolic dysfunction can be another side effect, but in those patients, the wall motion abnormalities often do not correspond to coronary artery territories. So the mechanism remains unclear. We've also seen apoptosis of epicardial cardiomyocytes and endothelial cells of distal coronary arteries in vivo models of 5-FU rabbit studies. And in these rabbit models, we've seen myocarditis-like inflammation. So is that the cause? Takotsubo cardiomyopathy is another manifestation in case reports of 5-FU cardiotoxicity. So is it sympathetic overdrive? We don't know. In some patients, there has been a transformation of the red blood cells into echinotic shapes. This leads to increased blood viscosity. This leads to decreased oxygen carrying ability of the red blood cells, and this can lead to coronary ischemia. There is also, the Kunis syndrome, which has been described, which is basically 5-FU causing some kind of allergic reaction and manifests with cardiotoxicity. And this is a very nice illustration by Dr. Shiga, who I know is on the call and will be in the panel discussion later, just illustrating the different potential mechanisms that I've just discussed. We've got the thrombosis, spasm, direct myocardial damage, and then could it be free radicals and oxidative stress? So a lot of different potential postulates. Let's come into a bit more detail on some of them. Nitric oxide, which is produced by endothelial nitric oxide synthetase, is a determinant of cardiovascular tone. Now, 5-FU potentially interferes with this pathway, and this may potentially cause coronary spasm, and this can be mediated by protein kinase C. We also know that endothelin-1 is a vasoconstrictor, and this plays a key role in vascular resistance and capillary blood flow. Raised levels of endothelial-1 have been seen in some patients with 5-FU cardiotoxicity. So is this the cause? Again, like with a lot of 5-FU studies, the data is contradictory. Some studies have actually shown similar plasma levels in those with 5-FU, irrespective of whether they have cardiotoxicity or not. So may not be the explanation. Protein kinase C and acetylcholine, they both have roles. A protein kinase C inhibitor, staurosporin, reduced 5-FU vasospasm, whereas an activator increased vasoconstriction. So is protein kinase C key in the pathogenesis? We don't know. Acetylcholine may also have a role. 5-FU may reduce acetylcholine-mediated vasodilation. This has been shown in some animal studies. So that was a kind of very quick run through of the clinical picture and the potential, pathological explanations of how this occurs. But now let's move on to the management. Now, 5-FU has been shown to increase the expression of thyroxidine interacting protein. Calcium channel blockers such as verapamil and diltiazem reduce the transcription of this protein. Is this the basis for the clinical use of these drugs? Unfortunately, as described before, there are conflicting results, and that's a common theme. Now, in the acute setting, what should we do? If the patient's getting chest pain, we should stop the drug and the patient should seek medical advice. ECG and troponin are very key here. We should give sublingual GTN. You can give calcium channel blockers, nitrates. You can give IV GTN. And if the chest pain continues, an echocardiogram to look at wall motion abnormalities. And then, if the pain is continuing, ECG changes are, abnormal. And if there's troponin is elevated, you would consider coronary angiography in this context. However, there's no evidence to suggest that treating any lesions that are found decreases the risk of subsequent cardiac events or decreases the risk of subsequent 5-FU cardiotoxicity. In the US, uridine triacetate has been approved for use in fluoropyrimidine cardiotoxicity. This is not available in the UK, however. If with the conservative management chest pain stops, then you may consider stress echo, stress CMR, or even a CT coronary angiogram to assess the coronary anatomy thereafter. And if there's going to be re-challenge, you may wish to consider pre-treatment with calcium channel blockers, nitrates, other vasodilators. If it's felt to be too high risk, then there is the option for alternative cancer treatment. In the UK, raltetraxate is sometimes used in these patients. In other countries, such as Japan, S1, which is an oral fluoropyrimidine drug containing tegafor and gemerasil, this is sometimes used as an alternative. This is a nice kind of flow chart illustrating what I've talked by Dr. Arjun, really just explaining how you may wish to pause, investigate the patient, and then consider re-challenging. So let me come on to re-challenge in a bit more detail. This is definitely an important consideration for these patients. In general, re-challenge is probably not recommended. There is a definite risk of further cardiovascular complications. There's a definite risk of death, actually. This is important. In this series by Saif Shah and colleagues, 13% of patients died with re-challenge of fluoropyrimidines. However, re-challenge may be necessary because disease is progressive. There may be no options, and raltetraxate or alternatives, may not be available or may not be suitable. And let's look at this study from the University of Pennsylvania, where they, carried out re-challenge in 11 patients, consecutive patients, successfully. So these were the 11 patients that they re-challenged, and you can see that they had a variety of malignancies. They had GI cancers. They also had breast cancer here, male and female patients, and the age from 48 to 70. And the treatment that these patients got at the beginning included either oral or intravenous therapy. Some of these patients went on to have coronary angiography, and some of them went on to have stents as well. Thereafter, they had either coronary angiograms, or they had nuclear testing, or some other form of functional stress testing. How did they re-challenge the patients? So you can see that for some of them, they decided to re-challenge them as an inpatient. Some of them, they decided to re-challenge as an outpatient. Some of them were intravenous. Some of them were oral capecitabine re-challenges, and these were all successful. This is the protocol that they used for re-challenging. This is the protocol they used for 5-FU. They changed from continuous to bolus infusions, and they preloaded with nifedipine and nitrates diltiazem. This is the algorithm that they use for capecitabine. Again, they pre-treated with nifedipine and nitrates and diltiazem here. So, it's all great to kind of re-challenge after the event, but is there some way to predict who will develop cardiotoxicity, in some way to maybe prevent that in the first place? So the dihydropyrimidine dehydrogenase gene represents the initial step in the catabolism of pyrimidines. And we know that its deficit is responsible for potentially life-threatening toxicities when fluoropyrimidines are administered. So can this help us in terms of cardiotoxicity? As you may have guessed, again, it's controversial and contradictory, the evidence here. There have been some studies which have suggested that potentially this may be helpful in predicting cardiotoxicity, whereas some studies have shown that this may not actually be of benefit in this context. So, what do we do in clinical practice? So if there's a previous history of coronary artery disease, you can consider stress testing, you can consider invasive angiography, but unfortunately, whatever result you get, that doesn't necessarily predict the outcome of subsequent treatment with 5FU. Negative tests, so by that I mean if the angiogram is normal, or if your stress MRI scan or stress echo is normal, that doesn't mean that the patient won't get 5FU cardiotoxicity. And, in high-risk patients, and by that I mean people who have previous coronary artery disease who are on medical management, you may wish to intensify their management. You may wish to add in calcium channel blockers, nitrates, and vasodilators. But again, it's not clear as to whether that will definitively, decrease the incidence of 5FU cardiotoxicity. So what are the potential, future directions in this space? Heart-type fatty acid binding protein is a small protein which is unbound in the cytoplasm, and that's present in high levels in myocardial cells, and that's released into the circulation very quickly soon after ischemia. So that may be a way to detect these abnormalities early. Alongside that, there's something called the tie index, which is a measurement which is done with Doppler echo, so just a normal echo. And this can detect subtle changes in overall cardiac function. And what we've seen in some studies is that the tie index can fall quicker before other abnormal parameters. So this may again be an early way to detect toxicity. But probably this is the most, the best solution to maybe detecting the patients, and that's, genetic profiling and trying to identify, genetic polymorphisms which may be able to predict. So this is probably the most likely in the future to be the most beneficial. So in summary, I'd just like to say that cancer and cardiovascular disease are two of the leading causes of morbidity and mortality. High-dose 5FU or capecitabine is thought to cause coronary endothelial dysfunction, leading to spasm and possibly thrombosis. The pathophysiological mechanisms, unfortunately, are not fully determined, and there are lots and lots of postulated theories. We should terminate therapy if symptomatic, and then you can administer nitrates and calcium channel blockers in the acute setting. Unfortunately, the presence of traditional cardiovascular risk factors does not necessarily predict the development of cardiotoxicity. And probably more importantly, the absence of these factors does not mean that the patient will not develop toxicity. Pharmacogenomic studies and genetic profiling is likely to hold the key in the future for better preventive and interventional strategies. So with that, I'd like to end my talk there, and I'd like to acknowledge my collaborators and co-workers at University College London, Bart's Heart Centre, and at University College London, and my other institutions. Thank you very much.
Thank you, sir, for such a detailed talk on 5FU related cardiotoxicity. I guess we have 1 or 2 minutes left, so we would be able to take a few questions. So the first question is from Dr. Purvish Parikh. If 5FU cardiotoxicity occurs, for example, in acute coronary spasm, is it possible to re-challenge with capecitabine?
Yeah, so as I kind of showed from that study of 11 consecutive patients, they did re-challenge. Um, Clinically, what we do is we often assess these patients either depending upon the severity of symptoms with stress, cardiac MRI, stress echo, coronary angiography. You may treat, you may give the nitrates, calcium channel blockers, and re-challenge. However, unfortunately, there's no predictor of whether that re-challenge will be successful. Those two algorithms I showed from the University of Pennsylvania, the references were there. I would direct the audience to consider, using something similar when they wish to re-challenge.
Next question is from Dr. Sudeep Shrestha from Nepal. So he is referring to bradycardia as well as some sort of shortness of breathing, which is relieved by stopping infusion and salbutamol nebulization. And then few of the patients that he experienced were able to actually continue without further cardiotoxicity. So you think this bradycardia is probably a harbinger of cardiotoxicity, you can predict, or you think it is different from the cardiotoxicity that happens?
Sure. So I think probably it's different. We know that there's quite a large variety of symptoms. Some of them are potentially ischemic, chest pain. There's left ventricular dysfunction. We see VT. We see bradycardia. I don't think that they are all necessarily directly related. One will lead to the other. It's probably a spectrum. As Dr. Shrestha said, you would possibly consider stopping. You may give, salbutamol or anything to get the heart rate up, but it doesn't necessarily mean that these patients will then go on to develop chest pain. Of course, you wouldn't be using rate-limiting calcium channel blockers as a preventive in these patients. You would consider other agents such as nitrates and nicorandils, other vasodilators.
Okay. Dr. Ghosh, do you think there is any, very clear risk factors by which we can classify patients into high risk and low risk for 5-FU cardiotoxicity?
Yeah, so I wish that I could say yes. What I would suggest is that refer you to a recent document published by the European Society of Cardiology, where they've tried to risk assess different types of cancer patients, including patients who are due to have 5-FU. They use the traditional cardiac risk factors, and I think that you may identify patients with coronary disease, you may identify patients who have cardiac lesions that you may wish to treat. Now, that is really not to prevent 5-FU cardiotoxicity, but I think medico-legally you can say that you did investigate the patient for cardiac disease and you've treated any lesions. So, you have done the best that you can to prevent things, but unfortunately that is no guarantee that the toxicity will actually be prevented.
Yeah, Dr. Ghosh, there is a clear difference between the toxicity profile of bolus 5-FU and continuous infusion 5-FU. So
Yeah.
is there an impact on the cardiotoxicity also?
Yeah, so I think it's difficult because with the continuous infusions, some of the patients are diagnosed late. Some of the patients are not diagnosed because the chest pain is often very atypical. It's not exertional. It doesn't sound, like a squeezing pain or a heaviness or a discomfort. So I think it's again coming back to the point I made. It's a spectrum of cardiotoxicity. The studies, they're small studies. They do normally suggest moving from continuous to bolus in this context. Okay,
Dr. Bharat Parikh asked any prophylaxis. I think we have already mentioned regarding cardio calcium channel blockers, but there is no clear role. I think this is the same question. Next question.
Yes.
One good question is asked by Dr. Ajay Venur, is that if a patient has had a recent myocardial infarction, so when do you think we can start 5-FU in this patient?
Sure. And is this 5-FU induced myocardial infarction, or this is separate?
No, a patient has had myocardial infarction. Now we want to start treatment. So how long, whether we can start 5-FU safely or you want to wait?
Sure, sure. Okay, so I think it very much depends on what the status of revascularization is. If the patient's had a heart attack, if they are fully revascularized, and potentially you would want them to be stable probably for around a 4-week period without any chest pain, you would probably go ahead. Obviously, the cancer treatment, does have to happen within a time frame. Is there also cancer surgery being lined up? In these cases, the treatment of the MI may be really with bypass surgery rather than with stents, because then you don't have the dual antiplatelets for 4 weeks. You don't have the bleeding issues. So, in our center, these issues, we do always try and discuss them in the multidisciplinary team meeting, because, as I've discussed, there is no definite evidence. Each patient should really have an individualized approach.
Yeah. Thank you, Dr. Ghosh. I think in the interest of time, we can't take further questions, but I'll request you to please answer them in the chat box. And over to you, Kashish, for the next session. Thank you.
Thank you so much, sir. Over to the panel discussion. Our chairperson is Dr. P.K. Smriti, Senior Medical Oncologist from Mumbai. Thank you so much, ma'am, for joining us this evening. Our moderator is Dr. G.S. Bhattacharya, Senior Medical Oncologist from Kolkata. And the panelists are Dr. Govind Babu, Senior Medical Oncologist from Bangalore, Dr. Atul Sharma, Senior Medical Oncologist from New Delhi, Dr. Taro Shinka, Senior Cardiologist from Japan, Dr. Avirup Gua, Senior Cardiologist from United States of America, Dr. Ajit Venur, Senior Medical Oncologist from Oman. Over to you, GS.
Thanks a lot. I'll start sharing my slide, but I think I got a message that Dr. Babu is not available, because apparently Dr. Babu has had some medical emergency, so he is cut there.
Correct, sir. He has not joined us.
Okay, so and that would leave Dr. Venur as the only person on the medical oncology, and rest all are cardiologists.
So Dr. Atul Sharma is also a
there,
medical oncologist.
Yeah, fine, perfect. Thanks, Atul. And thanks, Venur, and thanks, Dr. Guha and Dr. Shiga for joining up in this. But before we start off, let me just try and tell you that what we would basically be doing is talk about something which people think is very innocuous, hormone therapy and prostate cancers. And their effect on cardiovascular when you're using hormone therapy for them. And before I start, I'll just tell you there's a paradox. The paradox has been that as we have become more effective, our toxicity seems to be increasing, and long-term toxicity still becomes a bigger issue. So now I start off with saying what the cardiologists, because we have a major cardiologist here, need to know is that cancer treatment has caused us to have much higher cure rates, and we have moved into a place where cardiovascular issues have come up. And I think we just heard that there are 4 methods of looking at it. Identify the high risk, detect the prevention of cardiotoxicity, treat cardiotoxicity, and approach it as multimodality. So I'll just start up by asking you all, if I showed you a picture and to my cardiologist, what would you feel looking at this picture? This is supposed to be where you are interacting on cutting. Any of my cardiological colleagues, if they want to answer this. Hello.
Hi, this is Dr. Guha. I wasn't quite sure about the question. Can you paraphrase your question?
I just put up a cartoon with a lot of things written on it, right?
Yeah.
But what I would actually try and ask basically is that if I put up this cartoon to a cardiologist from an oncological point of view, I really would ask you that what would you suddenly feel about it?
Too much information.
Too much information. And that's what exactly is happening in the field, because I have a feeling we're getting into what's called infodemics for most things, even in this levels. Anyway, so let's get out of it. That is an artistic sketch. Now, I'm going to ask you all, is there very few centers now have a cardio-oncological services, right? So Dr. Guha, I'm going to start with you, and then I'll ask the Japanese colleague, what do you think is cardio-oncological services?
I think cardio-oncology as a field is developing differently based on the expertise available locally. Traditionally, as you clearly highlighted, that cancer patients didn't used to survive as much, and now they're surviving. So a major part of cardio-oncology has been survivorship, or cardiologists getting interested in survivorship clinic, which used to be primarily run by oncologists. There's an importance of active cardiovascular interventions while doing treatment to avoid cardiotoxicity if possible, and then to have plans for cardiotoxicity when they happen. And then outside of that, in general, the field has a lot of research to be done. I call cardio-oncology to be at the point where we were in 1980s when it comes to cardiology, where we were just starting to do heart catheterizations like regularly. So I think a lot needs to be known. So research is a very important component of cardio-oncology. So I think those are sort of, in my mind, the major components of cardio-oncology.
Can our colleague from Japan actually add something to that?
Thank you very much. This is Taro Suga. Thank you very much for this.
Can you add anything to that?
Okay. It's the same consideration. It is very important to think about cardio-oncology service. That is one word. Multidisciplinary system is very important theme of this field. Just is one word, I think.
So Dr. Abhirup has actually very clearly, and Dr. Siga also has very clearly put it across, that this is a multi-dimensional subject and it has got multiple roles to play. And in the continuum of oncology, it starts before you start your oncological treatment and goes into survivorship. I'll just sum it up in that language and then we move forward. So when I say cardiotoxicity, Dr. Shiga, what do you think? What comes into your mind when I say cardiotoxicity?
Wow, that's the question. It's difficult to answer.
Fine.
Please.
Okay, Dr. Venur, can I ask you, when someone tells you cardiotoxicity, what comes into your mind?
It's basically, I would think of cardiac dysfunction leading to cardiomyopathy and cardiac failure, and less commonly ischemic events. But the first one which occurs to me is, a fall in the left ventricular ejection fraction and going into cardiac failure. Okay. Less commonly ischemia.
Atul, do you have anything to add?
So what they say is absolutely right. Other than that, probably with any kind of the arrhythmia, we encounter kind of the unstable the chest pain, and top of that, any thromboembolic phenomena anywhere in the body.
Dr. Guha, anything you want to add?
I think the word cardiotoxicity really needs to be changed, and it just needs to be vascular toxicity, because I think it's a systemic disease with systemic treatments, even though we have directed therapy. So traditionally used to be only cardiac specific. Even simple differences or changes in hypertension, as we have noticed in many agents, especially the newer agents like tyrosine kinase inhibitors, are also toxic effects of the drug, which can cause long-term adverse events. So it is not just events, it's changes in risk factors because of treatments which cause so. So I think it encompasses a huge spectrum, and that sort of goes back to your initial slide where you had a lot of things on this on the screen. So it is not just things which we thought of. It's not just anthracycline, it's not just trastuzumab. There's many agents and specific effects of each agent.
So it's just not heart failure, it's the whole gamut of cardiovascular disease which comes into play.
Correct.
So 30% of patients are eventually going to suffer from it on the long run. So let's jump across that. So
should have specifically said what comes into your mind when you think of cardiovascular toxicity, which is a whole new thing altogether, not just cardiac toxicity.
You don't.
I get what you mean. Go ahead.
Okay. See, the common thing of etiology of cardiovascular disease can be in two parts. One, it can be that you have what causes cancer also has vascular problems. And second part is the cancer has an impact on the vascular problem, and the vascular problem has a part. So anyway, I'm going to get out from this and just tell you that common factors which are there. I'm not going to get it. Time is a constraint, and that I'm going to try and see how we get into it, because we just heard of something. I want you all to keep this slide in mind. The role of cardioprotection, personalized intervention, survivorship, improving outcomes, treating cardiovascular events, and finally is enhancing survivorship. So keeping that in mind, let me get into the breast cancer. 65 years old, menopausal lady presented with a palpable left breast mass, 2 centimeter, Biopsy demonstrated an invasive ductal carcinoma, grade 2. No lymphovascular invasion. Estrogen 100%, PR 100%, HER2 negative. I'm going to ask my my oncological colleagues, both Atul and Teng, how would you treat this patient? Atul, Ajit.
Okay, it's from. Okay, so she had a probably just let me read it again. So she had a small lump. She underwent surgery, you say?
Yeah, she
Okay.
went to lumpectomy
Like
actually, basically.
So she probably should be a candidate for the hormone treatment. She's a candidate for the hormone treatment. Any medical history for card? Any medical history?
We'll come to it. Yes, I mean, at the moment, let's say we don't know this is what you have got. At this given point of time, she's 65 years old. I'm going to hold you here, Atul, and then go into my cardiological colleague. Dr. Guha. Dr.
Yes.
Guha, if I ask you something is that this 65 years old lady, what is her chance of being hypertensive as far as India is concerned, or being obese, or being diabetic for that matter of fact?
I think for all three, probably less than 50%, but individually, probably more than 50% for each of them separately. Diabetes is not as common as we know around the world, but hypertension and obesity is quite omnipresent.
Yeah, and in India, we say that we are the world's capital for diabetes. And we would expect something like at least 35 to 40% people being diabetic. Correct. So anyway, I would ask my colleague, I would ask Ajit. Ajit, would you put up something like a risk calculation for cardiovascular toxicity for this patient? Refer this patient to cardiologist for your, or you
I would take a history, of course, but I would not calculate the risk factors. No, not as routine.
Calculate the risk. Okay, perfect. Okay, so this patient takes radiation and gets a letrozole taken. This oophorectomy, why it came in here, I don't know, shouldn't be here. This is for another case which was there. She was actually on letrozole with radiation. Now keep in mind, when she has had radiation and letrozole, what is her risk for cardiotoxicity now? Keep in mind that she's 65. She's had radiation to the heart. You will be starting letrozole. What is her risk of cardiotoxicity?
I think if there's a radiation oncologist on the panel, they might be able to help with this question a little more. But nowadays, whenever we do radiation therapy, we try to avoid the heart. So we do something called IMRT or 3D mapping of the breast before radiation is given to avoid the cardiac silhouette. So in the current 2020-21 time periods, we would try to avoid the heart. Now, if they get straight radiation to the heart for some reason, that sort of opens up into a completely separate topic, I guess, which we're not discussing is acute radiation toxicity versus chronic radiation toxicity.
That part at all. But what I wanted to just bring up, and which you rightly brought up, that we have always had a feeling if you have a left-sided tumor and you were radiated, you would have radiation-induced cardiac dysfunction. But this radiation-induced cardiac dysfunction had data all from previous data, which are much before the newer techniques. Anyway, suppose this patient had come with a hypertension or had come with a some sort of, say, mild cardiac failure. Do you think, Benur, you would ask a cardiologist to see this patient before you started?
Yeah, definitely. If I'm planning an aromatase inhibitor, I would definitely take a cardiology opinion before starting around that. Yeah.
Atul? Atul? Atul, please?
Yeah.
Atul, can you hear me? Atul, we are losing you. Anyway,
can you hear me?
I can hear you, but we're losing you, it looks like.
Yeah.
Okay, fine.
Oh, so I said that definitely will ask for the cardiology opinion.
Just to tell you all about a question that I asked you that, you know, if any patient has a heart problem and cancer to overlap the two most common disease, the chance is as you grow older, when you start crossing, you'll find out the chances keep increasing that you're going to have both the disease together. So there is anywhere between 30 to 50% for a patient to end up with them to combine. This is also will tell you that if you have a breast cancer and a cardiovascular disease, they are interrelated. And if they're treated, you'll find longer you keep treating them, the higher is the chance you'll have it. I just asked you about this cool thing, and I said that we have the metabolic syndrome as a main challenge. Acronym as DOLE. Cardiologists love this because they see that coming up and say that there is a metabolic syndrome there. So I'm really going to ask Dr. Guha. Dr. Guha, how do you define your metabolic syndrome?
I think that is based on the standard definition you have on the screen, where they technically don't need to be diabetic. So the coming back to sort of the main question about the risk assessment. So a risk assessment happens as and when an oncologist refers to us, which is almost at a primary care level. It's not really a cardiology specific question, but you would want to control all risk factors before starting any treatment. So I think whatever's listed on the screen, you would want to, if possible, and if they qualify based on the local scoring system, which I guess in India, you would probably still use the ACC scoring system to start a statin to increase the HDL, and I don't know if that specifically helps. Then you'd also want them to have blood pressure control less than 130 or 80. So, and then if they have diabetes, you want it control A1C below 6.5 if you can. But again, as I said, these are primary care things. So I would say that an oncologist and cardio-oncology should include primary cares as well. And we had one primary care physician last time. So that these risk factors, which are sort of pre-treatment risk factors, can be controlled before starting treatment.
So perfect. This was already covered up, and let me tell you, these are some things that we have to keep in mind. This was a study up to 2001, which showed that actually radiotherapy has a problem. But then I put a caveat down there that's saying that this is not meant for it. Now I'm going to come down and say, I heard Venur say, I will choose, Ajit say that.
So in the ATTACK trial, the cardiovascular events were 17% in the anastrozole arm versus 10% in the tamoxifen arm. So yes, aromatase inhibitor definitely do increase the risk for cardiovascular disease. This is about endometrial cancer, which is different thing altogether.
Yeah, fine. So question is, people prefer it because it's favorable toxicity profile when compared to tamoxifen. And I'm just quoting that particular paper which brought this into the thing. And it's where bleeding comes down, thromboembolic episodes are lower, and we have the data. So now let me tell you that we just talked about screening. Screening for factors is mandatory, and it's a level 1, grade A. And many types of cancers actually can pick up a lot of things which you don't pick up on a standard method if you're not screening. Now, coming back to what I just talking about is, we had the DOLE. So this is a behavioral change that one would love to see. So I'm going to ask you all something. Do we ask for this behavioral change very often, Dr. Vinur?
Yeah, actually nowadays that's quite my personal interest to counsel the patients about lifestyle changes. In prostate cancer, there is actually a very simple acronym ABCDE. A standing for awareness and aspirin, B for blood pressure, C for cholesterol, D for diet and diabetes, and E for exercise. So that's easy way of this. Bhangaras is much more easier, I think, to remember.
Anyway, so let's move.
So yeah, I do advise patients.
Okay, and I think the cardiologist will support you in saying that this is very important. If you
Yes, can I add something?
Please, Atul, go ahead. Yes, Atul.
The only thing I was saying is that probably if you see the meta-analysis, it says the risk of the cardiovascular disease or thromboembolism is higher with the tamoxifen versus AI. It's probably almost the double. So I am not sure about the endometrial study, but the meta-analysis says the risk of the cardiovascular the thromboembolism is higher with the tamoxifen than compared to the AI or less.
Atul, I will come to that. I'll just to you all that certain things that happen. So anyway, whenever you actually intervene with this lifestyle changes, you get a positive change, which actually brings down the risk factors and tries to help you during your treatment. I will jump across this and come back to what you were talking about. This is the ATTACK study in totality. If you watch carefully, yes, the number of all-cause deaths seem to be higher with or similar in both, but death from recurrences favors anastrozole, but death without recurrence fails tamoxifen. In fact, there is data to suggest that tamoxifen is kind of cardioprotective, at least because of an indirect effect, while other ones are not. Anyway, let's move ahead and try and tell you that this is something that is there, and therefore the question that we shouldn't throw tamoxifen out in hormone therapy in breast cancer in patients who have cardiovascular risks. Yes, tamoxifen increases thromboembolism, but I think a cardiologist can take good care of it. Okay, so that's how the warnings have also been there. And we do know something that the randomized trial that was done called LEAP showed us that it is pro-arthrogenic. So please, as rightly Dr. Abhirup, the start off, look at the whole picture, take care of the basic things like your triglycerides. And he brought up something that was statins. And I'll tell you, there's metabolic syndrome, and if you don't need to have that initiation of statins. Dr. Guha, can you clarify that?
So, I mean, statins are definitely helpful from the standpoint of when you calculate your 10-year risk and start statins based on that, based on the ACC guidelines. The problem with that approach is that, the risk calculation, which is calculated, does not include cancer as a variable. So, or sort of the cancer stage, information about the cancer. So, I personally tend to have a lower threshold, and I go with other clinically relevant information, which might be some variables of the metabolic syndrome itself, to decide if I want to put the patient on at least a low dose statin. Another effect of statin, which is the pleiotropic effect of statin, which is much harder to quantify, is seen in long term in many studies where statins were prescribed to show overall reduced better outcomes in the long term. So these are studies which are ongoing right now, which you would probably see results in a few years. But I have a low threshold to start statin if I can, if these patients are referred for risk stratification to me.
Perfect.
Dr. Guha, Dr. Guha, would you like to say anything about metformin?
So that's another very good question. So metformin similarly has been found to be cardioprotective even in patients who are not diabetic. So if you have an A1C of 6.5, which means your diabetes is well controlled, and you're on metformin, it's not bad to push it down further. But I don't think so. There's still data to suggest that in non-diabetics, we could use metformin for risk stratification further. If we were to choose a medication for diabetes management during risk stratification, and they are not on metformin, then metformin should be the #1 choice.
Yeah, I mean, I just put that in this slide out there. I'm going to really ask you, since you brought it up, what about using clopidogrel?
I think that's an overkill, I would say.
Or aspirin?
So aspirin is another agent which, honestly, even in the field of cardiology, I mean, we have gone back and forth between the use of aspirin. Can you hear me?
Yeah, now yeah.
Yes. So even in the field of cardiology, we have gone back and forth regarding aspirin and its effects and benefits. So I'm just going to go back to sort of a completely different group of patients. And these are diabetics, which was studied in 2020 or 2019 New England Journal studies where they used aspirin for primary prevention. What we found is the risk of bleeding is higher and the overall benefit in a large group of patients for diabetics is lower. Even though there's no studies which have done that, the only group of patients I would recommend using aspirin for primary prevention are those with colon cancer, just because the data for prevention of colon cancer has been pretty solid. And it is recommended by the USPSTF guidelines to use it in colon cancer patients. In all other patients, I would use it as long as you have an indication already to use it.
Perfect and well put. So, but still the area is gray. We don't have it.
Yes, for sure. Yes.
Now, this patient was 41 years old and a premenopausal, the same data which I had given. Ajit, would you add anything to the hormonal therapy?
No, I would use tamoxifen, but she doesn't seem to be at pretty high risk, so I would not use GnRH, goserelin or leuprolide for her. I would just stick to tamoxifen.
Okay. Atul?
Yeah, tamoxifen is a good choice. Of course, yes.
But would you like to use a general concept
More to add.
based on the soft and
Not negative.
Okay, let me try and put it that way. She has 3 nodes. Or
Yeah.
rather, 1 node. She has 1 node positive. Ajit?
Yeah, probably you could persuade me to start using it.
Okay. Ajit, I just want to get into something is that GnRHs are not absolutely safe, and we are using them large number of premenopausal women, and we are using them for long term. And remember, I just showed you a slide. Over the period of 10 to 15 years, we see that side effects coming up, and that GnRH actually can cause a lot of issues in males and in females, and this data is a known fact of hypertension. In males, this becomes a major issue because of severe prostate, we often use them, and in younger patients. I'm going to ask Abhirup something. Abhirup, Dr.
Yes.
Guha,
Yes.
Dr. Guha, I'm going to ask you something. This drug GLRH are known to cause something called stiffening of arteries, and they cause a lot of atherosclerotic vessels without raising the cholesterols.
Mhm.
They're stiff vessels. Any idea?
Arteriosclerosis is what.
Yeah. How do we handle this basically?
So, what we would see because of arteriosclerosis is what you're trying to handle. So you're trying to handle isolated systolic hypertension, which would be what you would probably see. So you would probably want to use afterload reducing antihypertensives like hydralazine or calcium channel blockers. But this will be used based purely on knowing the mechanism of the drug. There's no specific data as that these drugs prevent the adverse events of these agents. So that connection is not there. What is there is sort of logically how I would proceed. And this brings up the question which I had raised initially. These things need research. So I think a preclinical model to show why that happens is very important to then study the drugs which would be effective.
Sure, Dr. Guha, if you can put your mail ID in my chat, I will send you the data of some lovely work carrying on in Vanderbilt Hospital so that I can show you on this material. And I'm going to just tell you, this is one of the methods of looking at risk scores. You talked about a risk score, which we cannot use because that's odd risk, doesn't include cancer. So here is a risk score called the MESA risk score of 2015, which often is used in cancer basically, and in Europe specifically. I'm going to get across this, and I don't want to get into it. This has already been discussed, so I'm not getting into this part at all. But just to tell you all that, irrespective of the stage, if you have a cardiac dysfunction as a breast cancer is concerned, you're bound to land up with poor outcomes. And please remember, higher the stage, higher you see it. So we'll jump across this. It's come across here. And I will get into something called cardiovascular screening and surveillance, because at the end, it's surveillance keeping the patient well. I'm going to ask Dr. Guha. Dr. Guha, how often do you ask the patient who's been on a hormonal therapy? You know that the main causes are basically secondary, like putting on weights, lipid changes, or things like small vessels disease, which you actually can't do too much with your ECG, etc. How often do you think that we should be doing these long-term things like, waist circumferences, cardiological assessments? How long should you be carrying on? Keep in mind that today tamoxifen very often is asked for beyond 5 years to 7 years. Most hormonal therapy for breast cancer carries on for 7 years.
I think, and I think we started with Dr. Benir saying that this is not a cardiology referral automatically. So I think this needs to be a referral to primary care to make sure that diabetes, hypertension, hyperlipidemia are managed well. That's it. If they need to see every 3 months or every 6 months, that's up to the oncologist and the primary care physician. But I don't think so till they develop a cardiotoxicity, which is more now in the realm of actual cardiac diseases, they need to be followed up chronically with cardiologists specifically.
Okay. Ajit.
Yeah.
And Atul, for you all, this androgen deprivation therapy is the backbone of CA prostate treatment. Do you all agree with me?
Yes.
Okay, perfect. So do you believe in maximum androgen deprivation or combined androgen deprivation or a single androgen deprivation?
Now I think the trend is to give combined right from the beginning, both goserelin as well as abiraterone.
Combined.
Yeah, it is a combined. Is shown to improve survival. So yeah.
Okay. So let's put it this way that we started off treating CA prostate with diethylstilbestrol. The drug has gone off the market because of its major side effects. We have moved into using anti-androgens, and I'm not considering abiraterone or enzalutamide in this group, although they basically have an anti-androgenic effect. I'm more looking into the anti-androgen monotherapy in the classical terms of the glutamamides, and of course, in terms of your this thing. Anyway, so let's get into it. Let me ask you something. Suppose you were using a drug like GnRH agonist, grossolin, or loperamide. Let me ask you something. Those are the side effects that we would see.
Yes, 2 minutes left, please.
Just got 2 more slides. And
Thank you.
So don't worry. So the question remains is, we all know that these drugs are vasculopathic and they are cardiopathic. All right. But unfortunately, the meta-analysis that we see that comes from the clinical trials does not show you this compared to the real world data. On my left, what I'm showing you is the real world data. On my right is supposed to be what's the outcome from the clinical data from the trials. Your thoughts on it, Ajay, in a one line, and then Atul on one line.
I agree. The data is discordant. If you go by SEER data, you know, the MI, the diabetes, everything seems to increase with GnRH, while the randomized trial, the meta-analysis of randomized trial does not show the this adverse effect. So I cannot explain why it is so.
Abhirab, would you say the real world is different from the trial world?
Actually, this question is timed very well. So actually, that's a paper which we have working with even Dr. Ghosh on it, being presented at the American Heart Meeting, where we are looking at the real world data from the United States. For sure, in the long term, these effects are seen in more in combination than in single drug therapy, and mostly nowadays combinations used as our oncology colleague said that they are actually more efficacious for prostate cancer treatment. So I totally believe that there is cardiotoxic effects or cardiovascular toxic effects. What is difficult to study, however, is in a clinical trial, you have a 3-year or 5-year follow-up. If you look at a population of prostate cancer, you have patients who survive long time. And a very recent paper in the European Heart Journal will show that more people die of cardiovascular disease than prostate cancer itself. So maybe this contributes to the risk factors, which then leads to cardiovascular death in 10 years. But it's hard to study that in a clinical trial, because in clinical trial, as long as the prostate cancer got better, you have better results.
Well put, Dr. Guha, but that means we need to be doing the same thing what we did for the breast cancer patient. Close surveillance follow-up, check out for your high-risk factors, take care of them, and go forward with them. Just to show you all that what's possibly the mechanism of this appearing direct and indirect. The definition of metabolic syndrome slightly differs in males. And this classical syndrome, please remember, is the classical metabolic syndrome, and the one that develops in CA prostate from these drugs are not similar. There is a difference. Keep that in mind, because that is something which calls for research, as it was put right in the beginning. So now, before I close up, that's supposed to be what we do basically to try and see how to overcome them. Active exercise is always healthy diet and possibly chemo prevention. ABCD, and that was something that Ajay took away right in the beginning, saying that's what we all follow. To
just lifestyle. Yeah.
He has of his own, and I think that's where it is important. And with that, I will say abiraterone acetate and enzalutamide, and I will stick to abiraterone acetate. Okay. How often do you see hypokalemia with abiraterone, Ajit?
No, we compensate for that by giving prednisolone, so we don't see it. But we do see hypertension occasionally.
Atul?
Yeah. The hypertension is one of the problems with the abiraterone. You need to monitor them. So hyperkalemia is like Ajit says, we can see use that prednisone doesn't make much of a difference. You don't see so often.
So you
yes, thank you so much.
Yeah,
please summarize.
Yeah, so I'm going to summarize by saying that we treat the cancer patient for a cure, but let's not break the heart. And when I say heart, let's not even kill the blood vessels. We need to be making sure that we follow a continuum of care. This care has to be jointly between the oncologist, the primary physician, and the cardiologist. Some parts have to be taken care by the primary physicians, specifically those that form the common problem of chronic disorders, or what I said, toll. And we take it forward from there. Rest, I would say thank you. And thanks a lot for the opportunity. And thanks, my panelists. I think we all did a reasonable job.
Thank you.
Thank you so much, sir. Now I'd request our chairperson, Dr. P.K. Smriti, to please do the question or some moderation. Over to you, ma'am.
Yeah, so this is a question from Dr. Amishora. Before letrozole, do we routinely do lipid profile since he does it in all? So anybody from the panel would take this?
Ajay?
Ajit, when you...
Yeah, we do a complete profile including sugar and lipids before we start. Basically any treatment in the older group.
Yeah, so I think this point was already touched upon during the panel and it was brought out. Dr. Guha, would you like to say something about this?
I mean, you know, as long as the risk stratification is done properly, I acknowledge that studies have shown these patients with specifically aromatase inhibitors have higher incidence of cardiac toxicity. But what I do say that if you risk factor control as much as possible, I don't think so the science is far enough to say even in those people who are going to have cardiotoxicity. So I think just do the ABCD and let the treatment happen for the cancer.
Yeah, I think that's very important, and I think this point that Dr. Vivek Agarwala brought out about tamoxifen versus AIs, that exposing patients to 7% higher cardiotoxicity. I think we have to give the benefit of the treatment, and as Dr. Gua said, pay attention to the ABCDE and proper risk stratification and taking care of all the risk factors. And I think that is very important rather than deny the benefit of the treatment. Next question, please. Yeah, and this is again from Dr. Vivek. What to do when CVA happened on letrozole in the adjuvant setting? Anybody in the amongst the panelists? Dr. Atul?
Atul, Vivek, you will, Ajit, you would like to take?
So as far as I know, letrozole does not increase the risk of thromboembolism. So probably it's unrelated. I would take care of the other risk factors and continue letrozole. I know for a fact that tamoxifen increases, so I wouldn't be in a hurry to shift to tamoxifen.
Yeah, I mean, if the CVA is because of embolism or thrombosis, or if it is because of thing, then it's containing letrozole is fine. Otherwise, if you know what the cause is and if you know if there's some other reasons for it, it's then cut it off, specifically if you have other issues. But I don't think you need to switch over to tamoxifen. Letrozole is absolutely fine. In fact, the safer drug among all these drugs is exemestane.
Yeah, so I think we've already answered this question, and if there are no more questions, I'd like to thank Dr. G.S. Bhattacharya for that excellent moderation of the panel, and also the panelists and for their answers and the discussions, and especially Dr. Guha again and Dr. About answering all the questions. And I think then we can, if there are no more questions, we can move on to the next program.
Thank you.
Thank you so much, ma'am. We'll move on to the case presentation. Our chairperson for the case presentation is Dr. Jyoti Wadhwa, Senior Medical Oncologist from New Delhi. Thank you so much, ma'am, for agreeing to chair the session. I request you to please introduce our first case presenter. Over to you, ma'am.
Thank you. Let's start with our session, which deals with acute cardiotoxicity after immunotherapy. And we have two case presentations lined up. First by Dr. Vikas Talreja. He's a medical oncologist from Safdarjung Hospital, Delhi. So Dr. Vikas, please.
Thank you, ma'am, for the kind introduction. May I have my slide set, please?
Sure, sir. I'll just share the same.
Perfect, perfect. Immunotherapy, as we have seen over the past few have revolutionized our way of treating all our patients. And most of the time we feel it's a fail-safe injections, not associated with much side effects, but we have learned it in the bitter lesson, and that's where I am going to tell about a patient. Um, I started my journey with Tata Memorial Hospital with the DM. I am in Safdarjung Hospital as of today, and from tomorrow I would be changing my gears to Kanpur for being the consultant medical oncologist. Next slide, please. I thank the organizers for a wonderful platform for this case. So back to the first slide, please. The patient was an 80-year-old father of a medicine professor, had a comorbidities of diabetes, hypertension, BPH, glaucoma, was diagnosed as metastatic pleural lung cancer, sites of metastatic being pleural effusion, skeletal mets, lymphanginitis, and the molecular profile was negative for him, and the PDL1 was 80%. He was started on single agent pembrolizumab, and he presented to the emergency with shortness of breath on day 3. Next slide, please. The ECG at the baseline, you could see that there was a severe left axis deviation, considering an 80-year-old with diabetic hypertensive being risk factors, ST segment depression in 2-3 AVF, intraventricular heart block, low QRS amplitude, acute coronary syndrome diagnosis was made. Next slide, please. And angiography and a 2D echo was done. Unremarkably, the 2D echo was quite normal, ejection fraction being 55%, and an angiography demonstrating quite unremarkable coronary vessels as compared to being an 80-year-old diabetic hypertensive with a non-critical stenosis in non-critical arteries. Next slide, please. And even though with the conservative management, he went into VT and also pacing. And next slide, please. VF was demonstrated. The baseline, the cardiac markers were this NT-proBNP was 10,000, so CPK-MB was 82. Rest all were nearly normal. Next slide, please. He was managed with broad spectrum antibiotics, didn't revive, was given inotropes, failed to survive the non-invasive ventilation, went into invasive ventilations. We gave anti-arrhythmic agents, amiodarone, TC cardioversion was done, yet he succumbed. The only issue was that no steroids was given for him, and that was the bone of contention because he presented to the cardiac center. Next slide, please. And over the years, we have seen that everywhere in the safety analysis of all the studies, be it the nivolumab, there has been one cardiac arrest. Next slide, please. In the pembrolizumab also, there has been acute cardiac decompensation of one patient over many hundred patients. And next slide, please. And over various admissions also leading to the discontinuation or requiring interruption of the therapies, the cardiac has been a significant factor all throughout. Next slide. And we have found in the phase 1 studies that it's basically when you give these drugs at a supra normal doses, nivolumab being given 20 milligram per kg, ipilimumab giving 15 milligram per kg once weekly for 4 doses, there has been deaths due to myocarditis, T cell activation, phagocytosis, and antigen presenting cells. Altogether, summing up that it's not a fail-safe drug, and we need to be very careful, especially for elderly patients with comorbidities, for giving these injections to them. Thank you for the platform, and I will give my to the organizers and the chairpersons.
I now request Dr. Prashant Mehta to present his case. Dr. Prashant is medical oncologist from Asian Hospital, Faridabad.
Thank you so much, ma'am. So I'm presenting another similar case actually. This was a 70 years old gentleman, ECOG PS1, organ functions were normal, cough, hemoptysis for a few weeks, and this supraclavicular node. And imaging relieved these findings, left upper lobe lung mass, adrenal deposits on PET-CT, 2 liver lesions, and he did not have any actionable mutations. And PDL1 was 70%. Again, started on single agent pembrolizumab. After the first dose on day 3, same as Dr. Vikas's case, he presented in the emergency room with severe breathlessness and sudden onset breathlessness. BP was low, hypotension, 80 systolic, and ECG showed sinus tachycardia. And immediately I was called on the phone and I suggested to administer steroids just out of the blue, 2 mg per kg methylprednisone. Admitted in ICU, chest X-ray had bilateral infiltrates. Echo showed LV ejection fraction of 20 to 25%, global hypokinesia. NT-proBNP was very high, TROP-I was elevated. And CRP was moderately high, but procal was negative. Cultures were sent, CT chest was run, cardiology consultation, pulmonology consultation were taken, and the proper departmental echo was done later, and it revealed that there was a low ejection fraction and biventricular failure and dilated LV and some pericardial effusion, and he was diagnosed as acute severe heart failure secondary to probably IO. But he was put on BiPAP later, and pressor support, diuretics, and methylprednisone was given 1 gram once a day for 3 days, then 2 mg per kg per day. He was not improving, so we gave IVIG and a dose of infliximab as well, and he started to improve, and over a period of a week he improved. The CAG later showed that there was no significant CAD. He was discharged after 10 days of stay in hospital, and oral prednisone was given, and it was tapered over 6 weeks. The 2D echo after 3 weeks, again LVF was low, only DCMP findings were there. But post 6 months of the event, the patient was okay, and the imaging did show a partial response. He is not on any anti-cancer therapy and continues on cardiac medications. Thank you. So just shows that IO cardiotoxicity can be very early, and as early as even reported in literature as early as 1 day, and can be very, very severe. And steroids is the key. Thank you.
Thank you, Prashant. That was very interesting, and happy to note that the patient recovered from the cardiac side effects. So I now request the cardiology expert, Dr. Rakesh Gopal, to give his overview of these 2 cases. Dr. Rakesh.
Hi everyone. Immune checkpoint inhibitors, but definitely the in thing now, and it's, usually when the therapy was first envisaged, it was not known to cause cardiac side effects. So it was something which was celebrated as an oncology drug which does not have any cardiac side effects. But since the immunotherapy works by unleashing the innate immune system, immune cross-reactivity should rather be anticipated. And any organ can be involved, and myocardium is not an exception. Now, very serious immune-mediated adverse events can occur, and especially when you're using combination therapy. And immune-mediated myocarditis is associated with significant morbidity and mortality. Mortality could be as high as 50%. Genetic variants and microbiome may predispose some patients to immune therapy-mediated cardiac involvement. The CAR T cell therapy, however, works by adaptive immune cell transfer, and it is associated with cytokine release syndrome, unlike the immune therapy, where the immune-mediated myocarditis is the norm. So maybe the shared antigen target of the T cell receptor sequences in the tumor and the cardiomyocytes may be the reason why this cross-reactivity occurs. CTLA4 and PDA1 both are really protective against immune-mediated cytotoxicity of the cardiomyocytes. So if you block this, the heart may really come under the immune attack, which is not intended. There is no specific autoantibodies which are directed against cardiac structures ever demonstrated. And in fact, the PDL1 is upregulated in T cell mediated myocarditis as a compensatory mechanism. So if you block that, it could be really be detrimental. The incidence of the cardiac involvement in immune mediated myocarditis is really low. It's about less than 1%, 1.14% when single agent is used, and it may be as high as 2.4% if combination therapy is used. And prevalence of the disease is about 0.5% with one single agent and 2.4% with the combination of CTLA4 and PD1. The problem here is like when the mortality is really high, this low incidence may be actually be a masked event. the real event rate may actually be very, very high. We are not recognizing it in majority of the patients. That's why we only see the sickest of the patients. When we use the combination therapy, when patients are diabetic and obesity, and they are probably the only risk factors which is independently associated with immune myocarditis. No routine cardiac side effects. I mean, usually the non-cardiac side effects are actually more common in patients who have a pre-existing autoimmune disease. But the people who have autoimmune disease are not particularly prone for developing immune-mediated myocarditis for unknown reasons. The cases both presented really was shown to have the events much earlier. The median time usually is about 2 months. But if you're using the majority of the events occur by about 3 months, but it can be delayed as much as 1 year. Most of the patients will have only mild symptoms like fatigue, myalgia, but it can rapidly progress to fulminant myocarditis. Patients can have both bradycardia or tachycardia, and half the patients who develop myocarditis will suffer from major adverse cardiac events like heart failure, shock, ET, and CHB, and cardiac arrest. And the death may be as high as something like 46%. In some series, it's about 50%. And myocarditis may actually be commonly associated with myasthenia. So these patients who are on ventilators for myocarditis related heart failure, and then you should probably keep looking for the onset of myasthenia, which frequently accompanies the same. Diabetes and obesity may be the only predisposing factor for immune myocarditis, and other coronary risk factors are not known to put the patient particularly at immune-mediated myocarditis. But there is a possibility that the plaques can get inflamed as a part of the immune reactivity, so these patients can have coronary events. There's another variety of myocarditis, is smoldering myocarditis. It can present over a period of time, and patient can present late onset LV dysfunction. But here also the mortality risk is very high. So it is almost same as the other form. It's about 50%. And it is very important that you make an early diagnosis. Majority of the patients do have an ECG change. It may not be very specific. As the first case, we saw the ECG actually showed a high-grade AV block and a complete heart block. It's actually not VT. In majority of the people, we do see some kind of ECG abnormality, and 30% may have atrial fibrillation, and up to 50% of the patients can have VT. Heart block is much more important because that is associated with a very high mortality. And if the patient develops heart block, the high-grade AV block, they should never be rechallenged. And you can use the troponin as a marker. If the troponin is elevated by more than 1.5 nanogram per ml, the mortality risk is very high. So if patients who are on treatment, you can use the troponin qualitative to measure the level of troponin so that you can assess the response. And if you taper steroids, if the troponin again surges, then that means you'll have to restart the steroid, or that will be life-saving. One thing important in echo is that 50% of the patients with fulminant myocarditis even will have normal echo when the early ejection fraction may be normal. And even those patients who had MACE, major cardiac events too, 38% of them actually had a normal ejection fraction. And regional wall motion abnormalities may be present. It may not be only a global hypokinesia. And what is essentially, so almost all patients have a abnormal GLS. So if you combine a GLS with echo, global longitudinal strain with a routine echocardiography, that is a very valuable tool to make an early diagnosis. Almost all patients will have abnormal GLS even when the ejection fraction is normal. A cardiac MRI is probably the gold standard, but its sensitivity is low. It's about 76%, but it's 96% specificity. Basically, it shows a late gadolinium enhancement, which is because of the fluid load in the myocardium. Late gadolinium enhancement is actually not very predictive of MACE in immune myocarditis, unlike other forms of myocarditis. That's something important. And using MRI in a patient who has significant breathing difficulty is practically very difficult, and most of the centers, including ours, we don't routinely perform cardiac MRI in suspected patients. Endomyocardial biopsy may be a gold standard for the diagnosis, but the problem with endomyocardial biopsy is that immune myocarditis is typically patchy, so you may miss. And again, because an invasive procedure and the risk of missing the involved segment is high, we don't routinely do it, and most of the time it's not required to. If you happen to do it, then you can immune histochemistry can show CD8 cells interspread with CD4 cells and macrophages. The problem with diagnosis is that there are no single test which is really of high sensitivity to make a diagnosis. Combination of the tests will be needed. More than that, high clinical suspicion is required, because in most patients this starts as like a flu-like symptom, or maybe just like a fatigue, effort intolerance, some atypical chest pain, and these patients on immunotherapy must be warned against that. And early starting of the methylprednisolone, not less than 600 milligrams per day are the patients who have survived. So we routinely give 1000 milligrams of methylprednisolone for 5 days IV, and then followed by oral prednisolone for about 8 weeks. And then we use the troponin to see how the response is. And some patients may require reduction of the steroid therapy. However, whatever said and done, high dose steroid is very much indicated. Without that, and whatever patient survival data, what we have is minimum dose is 600 milligrams methylprednisolone. So I think for the benefit of time, I shouldn't go much beyond this, but I should say routine heart failure therapy is effective in immune myocarditis, and that should be tried in all patients. Aggressive treatment is very much required for a long-term, immediate survival and long-term benefit. Rechallenge can be done because in some patients, after complete resolution of the symptoms and the troponin becomes normal, if the immunotherapy is the only therapy left, you can actually rechallenge. But currently, the ASCO recommends permanent discontinuation of immunotherapy in those patients who develop immune myocarditis. But maybe you can try one single agent, and then under supervision, you can restart both agents as needed if that's the only option left. But no rechallenge should be done in patients who have AV block and critical ventricular arrhythmias, because they are the worst of the patient with a significant myocardium at jeopardy. Such patients may not tolerate it again. And some 14% of the patients with immunotherapy can actually have stress-induced cardiomyopathy. It is non-inflammatory. And in that situation, acute coronary events may have to be excluded. MRI will have to be done to exclude myocarditis because immune suppression is not indicated. And patients on CTLA4 PD1 also are prone for atherosclerosis, and they can have atherosclerotic events, including the stroke and cardiovascular events. So cardiovascular events will take some, in this scenario, some time period. So it's not an immediate effect. It usually takes more than 1 year. So all these patients who do present request immunotherapy, their cardiovascular risk factors will have to be modified, and coronary angiography is usually not required unless it's an acute coronary event and it's atherosclerotic disease. And because it's an immune-mediated myocarditis, basically an immune-mediated vascular disease is also there, but most of the patients have non-occlusive coronary disease. Pericarditis is equally dangerous. There's some incidence only 7%, but 21% mortality is also reported in patients who develop immune-mediated pericarditis. And pericarditis is usually a myopericarditis. Myocardium is also involved. So there's an increasing role of immunotherapy. There's a significant risk of cardiac involvement with immunotherapy, unlike what we thought earlier. So a dedicated cardiac oncology unit will be required to recognize them, and early monitoring, early recognition of the disease, and early administration of the methylprednisolone is very critical. Thank you.
Thank you, Dr. Rakesh. Let's move on with our medical oncologist giving us expert overview. Dr. Tilak, please.
Good evening, everybody. Thank you very much, ma'am, for giving me the opportunity. I just have about 4 or 5 slides for the oncology overview. So very nicely discussed. I thank the organizers for giving this opportunity again, and a nice discussion of the cardiotoxicity of various drugs. So as we have seen, the mechanism of cardiac-related, immune-related adverse events with immune checkpoint inhibitors, mainly there are 2 mechanisms. One is there is breakdown of the immune tolerance to the heart mediated by the CTLA4 and the PD1 pathways, as they are sort of protective for the myocardium. But when this protective mechanism breaks down, the heart gets involved. Second is there is expansion of those T cells because of targeting a common antigen shared within the tumor and the heart. And it has been shown by knockout mice studies that when these antigens are not there, the heart is safe. But when these antigens are shared within the tumor and the heart, the use of immune checkpoint inhibitors can lead to cardiac toxicity. The incidence of cardiotoxicity, by and large, the largest study we could find was the WHO database, which said the range is about around 2%, 1.8 to 3.1%. Myocarditis being the common is about 14%, followed by pericardial disease about 13%, conduction abnormality about 7%, and stress cardiomyopathy, also known as Takotsubo's myopathy, about 0.7%. Among these, the myocarditis, as already mentioned by Dr. Rakesh, very high fatality rate. Almost 40% of the patients of myocarditis may lose their lives. It is nice that some patients treated have improved and done better, especially Dr. Prashant, very well managed. I think the high dose of steroids helped this patient with intensive cardiac care. Combination immune checkpoint inhibitors definitely have a higher chance of cardiac IRAE as compared to single agent. Now, this is a study of the WHO database, and we can see the numbers, 25,000, 49,000, 26,000, large number of adverse drug reactions reported. And here we can see that the maximum have been with avelumab, about 3%, and minimum is with ipilimumab, about 1.8%, and pembrolizumab, 1.9%. But what can be seen is that the myocarditis is very high, as close to the pericardial disease. The conduction abnormalities because as by and large in the single digit. So these two are the most important, followed by conduction abnormalities. Stress cardiomyopathy is little less in these cases. So the oncology perspective, if I have to put it as, is awareness of early onset of myocarditis. This mostly occurs immediately after the infusion, like it was seen in both the cases, or within the first year of therapy. Withhold the therapy during the acute event. And the current consensus statement, as well as the ASCO guidelines, they suggest that stop the immune checkpoint inhibitors, even if the cardiac immune-related adverse event is just grade 1. Do not re-challenge. So roughly to put it, it's basically rule of 2 and 3. Rule of 2 is there are 2 mechanisms with an incidence of about 2%. 3 most common presentations: myocarditis, pericardial disease, conduction abnormalities. 3 most important steps to be taken: suspect and evaluate, glucocorticoids for therapy in the doses mentioned, high dose, and don't start immune checkpoint inhibitors even if grade 1 immune related adverse events. That's it from my side, ma'am.
Thank you, Dr. Tilak. I really was impressed with the last slide of yours, summing it up so well.
Thank you, ma'am.
So let's take up some questions. So the first question is from Dr. Vivek Agarwala. 2D echo GLS biomarker monitoring. Are we recommending this for our patients before starting them on IO or during the treatment with IO? Dr. Shant, is anyone doing it routinely? Or is
so as I know, ma'am, Dr. Padmaj has got a study going on with his student of GLS along with 2D conventional 2D echo in trastuzumab-induced cardiomyopathy, but not for immune oncology related drugs, but definitely GLS is coming up. Maybe the cardiologist can throw more light on this.
So we do GLS echo for all patients who are suspected immune myocarditis. We do GLS for all of them. And also the troponin, we do the qualitative so that it can be used as to monitor the response. And especially when you taper the steroids, some patients who have a resurgence of troponin, if the troponin is more than 1.5 nanogram per ml, then the risk of death is very high.
But this is after the cardiac event, isn't it, Dr. Rakesh?
No, those patients who are symptomatic. So immune therapy, typically the patients just start coming and saying they have fatigue. That is the most frequent symptom I have seen in my experience. They say fatigue, effort intolerance, some kind of atypical chest pain, and then when they say I'm not well, and that is mostly the beginning. And if you do an echo with GLS in such patients, if you can pick up an early onset of pelvic dysfunction, and the GLS is abnormal even in patients who have normal EF and abnormal EF. So such patients can actually be started on steroids earlier. And that is probably the only way to save these patients.
Right. Are you recommending some regular interval monitoring of these patients on IO with ECG
yes.
and
Yes, echo with GLS. Echo with GLS. We do echo with GLS in all of them. Once in 3 months if they are on immunotherapy. But typically the presentation is not fulminant. Unlike the CAR T cell therapy, where you have patients present within 5 to 7 days with a fulminant CRS. But here the presentation is usually about 2 months to 3 months time. So the problem here is patients will feel better with immunotherapy. They go home and this event starts insidiously by about 2 to 3 months. So majority of these patients, we are not seeing them at that point of time. So we'll have to warn patients about symptoms, and if they're not feeling good, if they're feeling fatigue, if you're having breathing difficulty, they should report earlier. That is critical.
Dr. Tilak, as an expert, would you suggest monitoring the patients on IO the way we follow them up on, say, trastuzumab or anthracycline therapy? Would you recommend that we follow some sort of guidelines regarding their regular cardiac monitoring?
Ma'am, as of now, what is happening is these patients, they have to be on the lookout for the cardiac events, because as suggested, it can occur even after the first infusion. So they have to be told when to immediately come back, etc., or it can occur in the first 1 year. Though ASCO guidelines do suggest the ECG and echo, but I can't recall any regular monitoring as suggested for trastuzumab every third cycle or every second cycle like we do it for them. So, but maybe with the time changing, we might have to look into at least the GLS part of it if it shows a better correlation with the underlying myocardial abnormality rather than just plain echo.
The problem with immunotherapy was, when it was started off, initially, the initial clinical trials didn't show any myocardial involvement. It was supposed to be without any cardiac side effect. And that was the problem. Now, this incidence of very low incidence and very high mortality is an unusual disease. So if the mortality is very high, the incidence also should be higher. We are not recognizing them. So this is a time we'll have to innovate and then keep a watch, and then probably we'll have to make guidelines about it.
Right. Thank you, everyone, all the experts and the panelists. I think we need to stop here and back to the organizers. Thank you.
Thank you.
Kashish?
Over to you, Vivek. Sir. Thank you so much, man.
Yeah, I thank everybody for such a good response. I think we had a really wonderful session about 5FU related cardiotoxicity. Dr. Arjun Ghosh was simply wonderful. There was so much to discuss in the panel, and everybody felt that there was less time, but we can only discuss. Probably we would want to discuss more in the upcoming sessions regarding the hormonal therapy and the cardiovascular toxicity aspect. As in the immunotherapy and cardiovascular toxicity case session, I think both the cases were very well presented, and I think it really brought out the difference how using steroid in the second case actually saved the life. But in the first case, the cardiologist wasn't really sure that it is immune-related cardiotoxicity, so steroid was not given, and the patient actually lost life. So really. And I thank both the experts for bringing out the nuances in this rare toxicity so well. So thank you once again, and I invite you again to join our initiative by taking membership in the Asian Cardio-Oncology Society, and to join us again next Thursday for our 5th series. We are having wonderful sessions and wonderful talks ahead. Thank you and good night.
Thank you so much, sir. Once again, on behalf of the Asian Cardio-Oncology Society, I would also like to thank our supporters, Intas Oncology, South Asian Journal of Cancer, Indian Cooperative Oncology Network, and the Integrated Academic Society of Clinical Oncology. Thank you, everyone, and good night. Vivek, sir, with your permission, I will end the meeting.
Sure.
Thank you so much, sir. Good night.